Today, we are talking to Derik Sven all about dental hygiene governance. I'm really excited for this interview. Stay tuned. Hey everyone, welcome back to the Grow RDH Podcast. My name is Katie and I'm a dental hygienist from South Dakota. On the podcast, we always talk about all things dental hygiene related, and with the current trends and legislation, I thought the perfect guest today would be Derik Sven. I'm really excited to introduce our guest, Derik Sven, MBA, MPH, RDH, CDT, FADHA is here with us. He is coming with nearly 20 years of experience as a board certified dental lab technician and restorative dental hygienist. Derik brings a unique blend of clinical insight and technical expertise. He holds undergraduate degrees in dental hygiene and healthcare administration, as well as master's degrees in public health and business administration. Currently, he's pursuing his doctorate in health science at George Washington University, with research centered on dental hygienist autonomy and integration of dental therapists into healthcare systems. Derik is the current president-elect of the Virginia Dental Hygienists Association, and he is an inaugural fellow of the American Dental Hygienists Association. Derik is deeply engaged in advocacy and policy work across oral health professions. He is currently doing a 6-part series for RDHA Mag on dental hygiene governance. And so today we are going to talk all about dental hygiene across the US and highlight some major issues in the system. So Derik, would you like to say a few words just to introduce yourself, the man behind the titles?
Well, thank you for the introduction. As I like to joke when I'm on stage, I collect degrees for a hobby. It's a very expensive one, but that's kind of my thing.
Love it. And where are you originally from? Where were you, born and raised?
So I'm a Southern California native. I was born and raised just outside Los Angeles in Thousand Oaks, California. And when I was about 10, my parents moved me and my brothers up to the Seattle, Washington area, where I lived for about 30 years. That's where I went to school at Pima Medical Institute in Seattle. And then shortly after the pandemic, I relocated to the East Coast for grad school, where I am currently located.
Awesome. So how long have you been involved in the Virginia Dental Hygienists Association?
I got involved with VDHA almost immediately when I got on the ground. Advocacy work within our association is really important to me, and I wanted to get involved as soon as I got here. The great thing about Virginia is our association is very homogenous. It's very unified. Everyone is very welcoming. And I haven't always seen that in association chapters across the country. Shout out to the wonderful people in Virginia's Dental Hygienists Association. They're very welcoming. And I didn't seek the role of president-elect. I actually was just being an active member. I started to give some lecturing materials at different local components. And apparently I'm not great at keeping my mouth shut. And people started to realize I knew what I was talking about. And last House of Delegates meeting, I was sitting in the background just observing. I had no intention of getting involved at this level. I was going to spend a quiet year finishing my doctorate because I graduate next April, and I just wanted to get that stuff out of the way. And then I turned my head and somebody says, "We're nominating Derik Sven for president-elect." I'm like, maybe you guys should have asked me first. But nobody else wanted to run. So I said, well, I do have the knowledge for this, and with your guys' support, I'll take on the role. And it has become the role, because at that very time, I didn't know that ADA was going to be starting to put those regressive measures they put out in their own House of Delegates. And then my research started to become more of a real thing for advocacy, because everything I was doing was researching dental hygienist autonomy and how dental therapy might be integrated into the broader healthcare system. And so as the year began to unfold, I started talking a little bit more, now that I'm president-elect, about how I intended to run. I told the House of Delegates when they elected me, I intended to make dental hygiene autonomy the forefront of my presidential year. And I don't think everyone fully appreciated what I was saying at the time, because as the year unfolded, it became clear that these regressive measures the ADA was putting out were being taken up by local chapters across the country with devastating effect. And I told everyone, I said, look, we need to come up with a new plan. We cannot be sitting on our previous advocacy measures. We could not just be sitting back as the, just taking an attitude from dentists that so many chapters have adopted. We need to start looking at the idea that the best defense is a good offense. And so
Yeah.
that's how I'm leading in my presidential year.
And I think you actually even bring that up in your first article, right? The best
Yes.
defense is, say that again. The best defense is a good offense.
Yes. Another
Yeah.
part of my background, which doesn't really apply to academics, is I'm also a Krav Maga instructor. I teach self-defense. I've been doing that for the better part of a decade. And so that mentality of not looking at yourself as a victim is kind of ingrained in my psyche. And so when I see advocacy measures that are not proactive, it kind of stimulates that inner Krav Maga instructor in me. We're like, we need to realize we are under attack and we are justified in self-defense.
Yeah, it sounds like, wow, just a lot of your background and then the way you got into the president-elect position. It's just, everything is aligning perfectly to really, suit your strengths. I mean, that is a huge strength that we need right now. And everything is aligning to put you in a position where you need to be.
A little too fast for my comfort. There's been a couple times where I've just had to sit back and go, what the heck happened? Like, how did this snowball this quickly? But, I am where I am. This is where things have aligned. So I'm going to
Yeah.
do my best to lead with integrity and purpose.
I just want to share a little bit of a personal connection here. So it's interesting. I just graduated last April, actually, technically, with my PhD. And now I'm the president-elect of South Dakota. So I feel like we have a lot in common. And it was kind of the same. There really wasn't anybody else. And not that I was like the default person, but I've been secretary for years, and I just like to kind of play the back seat of helping people along, but really no one was stepping into the position. And I was like, I guess this is my year. I'm done with my PhD, which unfortunately you still have that on your burner, but it just kind of worked out where this would be my year too. So hopefully we can kind of connect on that president-elect journey into presidency, because I'm a little nervous about that as well.
Maybe I'll have some insight for you.
Yeah, for sure. Well, we'll just go ahead and get into the interview. I'll start with some of the questions that I had sent you. And again, if you want to, change anything or go in a different direction based on the question, take this whatever direction you want. So these questions are referring to your first article. And I know you said you have more coming out. The second one I saw just came out. So that's exciting. But in the first one specifically, you highlight the inherent conflict of interest when dentists regulate dental hygienists. And the reason I reached out to you for this interview is because I teach ethics and jurisprudence. And this is one of the main huge conflict of interest that I've been talking about. And it's just kind of this constant frustration. So can you explain the dynamic, how it impacts autonomy of hygienists and patient care?
Absolutely. So I think that and I think probably a lot of hygienists feel this way too, is when I was starting my career, I immediately noticed that conflict of interest, but I couldn't name it. It was there. This ethical burnout that started to happen almost immediately, where instead of being allowed to practice preventive dentistry the way we were taught, I was essentially being turned into a salesperson for restorative dentistry, which I have an interest in business. I have an MBA. I've run businesses successfully, very, very successfully, actually. And so I get and understand that. And I have a whole lecture I give on motivational interviewing, in which I show clinicians how they can use the psychology of motivational interviewing to become better at selling change, if you will, being good at getting patients to adopt healthcare that they need with reasons that they want. And so that part came naturally to me. But the idea that preventive dentistry was always being overridden by dentists, that I had dentists who would look at every single patient that came into the operatory as a potential $60,000 case where every tooth was going to be crowned. And then you had other dentists who would watch an amalgam filling for 20 years and it would still be viable. It's like, well, these are two completely different ends of the spectrum, and I'm not being allowed to use my preventive specialty to keep that patient's oral health stable. I have you guys trying to do different restorative procedures, and I'm now being torn in the middle. So that started to wear on me. And as I started to work in different consulting arenas, I saw different consulting groups that had highly unethical practices where they essentially just turned patient care into a Excel sheet of different procedures they were going to do on patients. They didn't do them based on need. They would do them based on how much money they needed for that month. And so the morality and ethics of oral health was just going out the window with these different groups. When I left dental hygiene school, I actually had real ambitions to become a dentist. I started pursuing the rest of my prerequisites for dental school. But then as I started to see this constant trend for overdiagnosis to meet financial targets and delivering these half truths to patients to get them to agree with it, I couldn't be a part of that system. So I needed to do something where I could honor my personal ethics and feel good about a career in dental hygiene. So I went back to grad school and got my master's in public health, started to study access to care issues, which I found helped me to recenter with the heart of dentistry, where it really is. But as I started to do the master's in public health, I also started to realize in researching public health initiatives that the majority of these sometimes really good public health initiatives would fail because the authors of these initiatives didn't understand business. And that's a common theme with public health is oftentimes it's this dichotomous relationship that people approach the two, where public health entities don't understand business, and so they don't really jive. My theory in this arena is that you have to understand both thoroughly if you want them to be successful. And then as I was finishing the MBA, I also started to realize a major component in advocacy was that so many of these individuals in business or public health didn't understand the legal or regulatory frameworks surrounding them. So I started a third master's degree in healthcare law before I got accepted to the doctoral program. I'm still technically enrolled in law school and intend to finish that law degree when I'm done. But that trifecta of understanding public health, business, and law is an incredible prism to view issues through. And I think that it gives real clarity when you look at those issues through all three. So when we start to talk about conflict of interest issues, as I'm working through my research, I came to that doctoral program. I'll just be honest with you. I was frustrated. I was angry at the system. I didn't really know where to approach this. And I told my professors that. And they're like, okay, I get that. That's great. You acknowledge that you're there. But they wanted me to do something positive with that frustration. So with the Doctor of Health Science program I'm working with, it's not a thesis that you do at the end. It's a multi-research program. So you start with basic research and then you work your way up to a practicum that's over 2 semesters. And then your final 3 semesters is a seminar series where you deliver original research. And I'll tell you what my original research is at the end here, because it's actually directly related to this. But my practicum series was actually looking at dental education and trying to come up with a model that would divest dentistry or dental education from the lack of concept it has in preventive care. So rather than having dental school where it's a 4-year undergrad and then 4 years of dental school with no residency afterwards, I looked at this as instead of taking that 8 years, you could, in theory, do a 2-year associate's degree in dental hygiene, 2-year bachelor's in basic dental therapy, 2 years master's in advanced dental therapy, and then finish the last 2 as a doctor of dental science. So you complete the full curricula of all 3 professions, but you start with the preventive foundation. And that was going to be my positive contribution to the field. So I'm publishing that research. I did a nationwide thematic analysis interviewing program directors of dental schools, dental hygiene schools, and dental therapy schools. And it was just a treasure trove of information that I got from all these amazing educators, dentists, PhDs. It really was a fun project to work on. As I was finishing that up, I was explaining some of my research at RDH Under One Roof to a very sage hygienist in academia. And she looked at me and she said, Derik, you're really paying, I think, too much attention to the restorative aspect of dentistry. And she said, do you understand? Dentistry is predicated on dental hygiene's failure. And that's where I got that quote that's now gone viral across social for the introduction. Yeah. And it really, really struck me. I had never thought of it in those words. But when you look at how to lessen oral disease, it's not through restorative care. It's through prevention. And that is what dental hygiene is. And I go on to explain in the article, because of my background as a dental laboratory technician and the unique training that you get in Washington State, where I got my dental hygiene degree, where hygienists by statutory law have to complete board certification in restorative dentistry. Your whole second year is layered with a lot of restorative care. You're doing, I don't even remember how many typodonts and amalgam and composite. And then you also have to treat, by the time I left school, I had placed over 200 fillings on patients.
Oh my
Live
goodness.
patients. Like it's a lot of work on top of all your other hygiene. But when you go through training like that, you start to view the removal of human dentition in a more favorable light, and you don't necessarily see that conflict of interest, the distinction between the preventive specialty of dental hygiene and the restorative career, surgical career of dentistry. They are two distinct professions, and they are in conflict of interest with each other. Everything a hygienist does is to prevent the public from needing a dentist. And so if you have dentists who have financial motivation to override your preventive diagnoses, that's a conflict of interest no matter how you slice or dice it. And now when you start to see these DSOs who are giving these associate dentists actual tallies of how many restorative treatments they have to do every day, they don't go into those operatories the way a hygienist does and say, this patient has an incipient lesion, I can apply Curaden, I could apply SDF. And I have a moral obligation to not surgically remove any tooth structure unless it's necessary, not because you have a tally of restorative treatment you have to complete that day. And so when I'm looking at a patient and the radiographs clearly show this is something that's reversible, and a dentist is going, well, I think we should just go ahead and do some fillings. Well, now that tooth is on a downward slide where a crown's going to be necessary prematurely. It's probably going to need to be root canaled at some point. They're going to lose the whole tooth, and an implant's going to have to be placed, which is, ching ching to the dentist schedule and the whole career of dentistry. That's how they look at patient care. They're not looking at it as, how can I stop this? How can I prevent it? Because it would be a conflict of interest to their finances.
Right. Yeah. As soon as you said, just a few minutes back, when you said something about the consultants, I was like, oh my goodness, between consultants and DSOs, I mean, that could be a whole other episode, a whole other podcast on its own, due to horrible impression that some of these DSOs are creating for the larger. I don't think all DSOs are evil. We actually have a DSO that operates very morally and treat their employees very well. Patients love them in South Dakota, but because they have this reputation of being a DSO, some of our students just really kind of balk as like, we're not going to work for any DSOs. And I'm like, the model can be employed the right way. DSO in itself is not a bad model, but when you get these consultants coming in saying we can up your production, we can up your bottom line, it's a no-brainer for them. And so it's so hard to, DSO comes with such a negative connotation, and it's just, to me, it's a sad thing because I've seen DSOs work well.
Yeah, I work for a DSO right now, and I actually like where I work because I have a very moral employer who is very conservative. He goes out of his way to be exceptional in that arena. He actually just he is taking on a whole bunch of just charity cases every week, and he's losing money from it. And I agree. The DSO model is something that's here to stay. We have to embrace it, and hygiene autonomy can work within it, and it actually can solve the ethical issues that we're facing. The problem with DSOs, though, is they have private equity that's coming into them, backing them, and those shareholders are expecting a return on profit. And so if your profit is based on restorative work, there is ethical issues. If your profit is based on preventive, your ethical issues are way less, because there's no way to slice or dice. Prevention's never going to be bad. It's really hard to overdo prevention. Yeah, you could, but it's not going to cause harm to the patient by doing more preventive work. If you apply extra Curaden to a tooth, that's not going to cause the patient harm. If you start carving up teeth, that will cause them harm.
So I'm just curious, this is kind of off the beaten path. Is any of your articles coming out in RDH Mag going deeper into the DSO issue?
Not so much the DSO. So part 3 covers the economics of hygiene autonomy. So I really hit that The reason why is because I actually view selling the idea of hygienist autonomy the same way that I view talking to patients. Is I need to find what motivates each individual in these broader conversations. So with the hygiene community, my message that we're talking about right now is resonating hugely. The viral posts that have gone on for the past 2 articles make that very clear. Even the YouTube video from my recent podcast with the wealthy dentist has already gotten a lot of attention. But I need dentists' buy-in and DSOs' buy-in too. And I know when I'm talking to hygienists, dentists' feathers, I'm sure, are being ruffled, and they're probably not happy with the verbiage that I'm using. I get that. I do not think all dentists are bad. There are some fabulous dentists out there who are highly skilled clinicians, know very much what they're doing, and are highly moral and very, very skilled clinicians. What I'm focusing on is the ethical dilemmas and the way the regulatory framework is set up. And I have to, when I'm doing that, I have to bring out the consequences for patients and the broader community and the hygiene community. So while I am making those points, and I do realize some people will find them negative, they have to be discussed because some of these things have been swept under the carpet somewhat deliberately. And if they're not discussed, we don't really understand the full consequences of what the ADA is currently proposing. And so Part 4 and Part 5 are going to be really heavy hitting. Part 4 is called Debunking the Premise. And the premise that keeps hygienists under the thumb of dentists is the assumption that they are the de facto guardians of all aspects of oral health, suited to govern them all by their education. And so we break down dentist education. They did bring this scrutiny. The fact that organized dentistry got out there and said, we think we have the expertise for on-the-job training to train hygienists on the job. You guys invited the scrutiny. That's entirely your fault, and I am bringing it.
Yes.
It's going to go into detail on it. Part 5 is going to be historical context of what happens when the ADA has deregulated other industries, and I have some very, very concerning evidence on that that's also going to be coming out. I mean, they brought this on themselves, and they're going to have to answer for it.
I think that's just so exciting and timely. Obviously, it's relevant. But how much, I want to also bring up the conflict of interest of governing a profession you also employ. I don't think there's very many professions out there that have that much control. And so when we're talking about conflict of interest, one of the other huge ones in my book is the fact that you are making decisions on the scope of practice, that what duties we can do on everybody that you employ. So you can ultimately make whatever decisions you want that benefit your business because you're acting as an employer when you're making those decisions. Can you speak a little to that?
Yes. So that's exactly why I brought the Federal Trade Commission issue into play in Article 1. And one of the interesting things, if you're doing the research on what the Federal Trade Commission has already ruled on, they have already ruled against organized industry multiple times, all the way up to the Supreme Court, where organized industry lost. And one of the interesting things in the Harvard Law Review that was the deciding factor in the Supreme Court ruling against organized industry was that the board members that they were ruling against were active market participants. That was the language they used. Board members actively participating in the market, making these decisions about other individuals. That was the deciding factor. Now, the Federal Trade Commission is a unique subject, and I think we have to approach this with some caution because it's a institution that is appointed by the governing president. So members have I think it's a 7-year term. There's 5 members and no more than 3. You can't have more than 3 people in the commission that are on the same political party so that there's at least a little bit of balance there. But with the current climate and what they're doing in Washington, D.C., deregulating these different commissions and whatnot, there's some political aspects to this as well. So while the legal precedent is there, the political arena does affect this.
Yeah. Do you think it would affect it more in favor of dental practices and what they're doing?
So I'll tell you what my research question is from my doctoral seminar thesis. I know it's not technically a thesis, but a seminar presentation. So my research question is, to what extent have partisan political alignments in the US shape the stringency of dental hygiene scope of practice regulations as measured by the ADHA Scope of Practice Index between 1984 and the present. Preliminary data would suggest, if you, I mean, just looking at the Scope of Practice Index on a map, it almost looks exactly like an electoral map. It's very similar. There's a high degree of yeah, but nobody's ever actually put that in a major research article. So that's going to be my contribution to advocacy. But yes, there's a very strong correlation with the politics of a state affecting the scope of practice for dental hygienists. And the political leanings, if you have a conservative state, they are more likely to have as much restriction as possible. And the more liberalist state, it's going to be less restriction as possible. Now, there are caveats to that, and the individual composition of state legislators can affect that. So, for example, Washington State, where I'm from, it's considered a very liberal state, but the legislature is actually, I'd say there was quite a few years when I was living there where it was actually controlled conservative. Surprisingly, governor would be liberal, and maybe one of the chambers would also be liberal. But it was usually divided government, which most people don't think of the Pacific Northwest that way. However, a great deal of Eastern Washington is very conservative. So they have quite a few red districts there. And there's a dentist on the legislature there who is also in a red district. And she is vehemently opposed to dental therapy and hygienists' autonomy. And so, unfortunately, you have those people and they get into the health committees and they cause a great deal of harm. We have almost the exact same situation in Virginia, where we have a dentist on the legislature that is going to be a difficult case for us to get around because, they're entrenched and they have money, and dentists, by far and large, are generally pretty well off. And so they can run their own political campaigns.
Yeah.
Did that answer your question?
Yes, it does. I feel like when we go to dental hygiene school, we're not expecting this much politics to be involved in just simply wanting to do our job. And to me, it's just kind of crazy. Continuing on the Federal Trade Commission and just kind of addressing those cases specifically that you already talked about, what specifically can hygienists or associations do to leverage that to promote autonomy? For example, specifically like in Arizona, what are their options? They're kind of the battleground state right now. That in Nevada's pretty much kind of done, but Arizona is in it.
Yeah.
So what options do they have?
So here's a point of action that all state chapters can consider, and I'm working on this right now. So every state, I think almost every state has a law school or more than one law school. Here in Virginia, we have a lot of them. And in Washington, D.C., there are a dime a dozen on every corner. And law schools have law clinics, and they will do pro bono work. So I would encourage every state chapter, if you do not have an active attorney representing the association in your lobbying firm, that you consider contacting your local law schools and talk to them about potentially helping with this. This could put certain lawyers on the map, and they might be willing to do contingency fees or pro bono work for the association, or at least a deeply discounted rate. And it is time for the dental hygiene community to realize we have partners that can help us in the legal community, and we need to reach out to them.
That is such an interesting idea. I love that. We have a law school where our dental hygiene school is located.
So go over there and talk to the professors in the law clinic and explain to them what's going on and see what they can do to help.
Yeah. If we already have, so I'm just going to speak on South Dakota. We do have a lobbyist who is so gracious and so generous with her time, I'll say, in that she typically just helps us when we need it. So what would be the relationship if we wanted to seek the law school? Would we need to talk to her too, or what?
Yeah, that's something I'm navigating right now because we have lobbyists also. They're not attorneys. And so if we bring a lawyer into the mix, how is that relationship going to work? How does the advocacy team coalesce? How is that all going to happen? So that is a discussion your advocacy teams have to work out. But I at least want states to realize there is potential there. And you should definitely not ignore it because we need all hands on deck.
Yeah, the more help you can get, right?
And sidebar note, for any hygienists out there that don't realize this, because this is something I talk to students about, law school is actually, becoming an attorney is I wouldn't say, it is, let me put it this way, it is easier for a hygienist to become an attorney than it is for them to become a dentist. Because the prerequisites for law school are a bachelor's degree in any subject and take the LSATs. So if you have a
Really?
bachelor's degree in dental hygiene, that's all you need. Take the LSATs and apply for law school. We need more attorneys on our side.
Yes, we need dental hygienist attorneys.
Yes.
Wouldn't that be an amazing like push for people that are really passionate about this? Like jump head first, right?
And law schools, there's like half a dozen of them that are fully accredited and fully online. You don't actually have to go on campus. So there's options there, people. It's a definitely a career you might want to consider.
Yeah. Yeah. So let's just kind of take this almost like a case study. So, say a state wants to reach out to a law school. In that initial first talk, and this kind of relates to one of my questions, but how would we approach a lawyer and say, what are our significant barriers? So, specific legal or regulatory barriers that we want help with. How would we approach that conversation?
So I happened to be at an event in DC, and one of the professors at Georgetown was there. And I just had a great conversation with her. And I explained to her about the FTC issue. I explained to her about my writings. And she had some fabulous insight that I didn't even think about. She's like, this actually could turn into a civil rights issue because the majority of the profession is female. And then she was looking at this. And then she also said, also, like, look at what they're proposing in Nevada, what they proposed in Nevada. It was shot down. But the concept of on-the-job training essentially indentures whoever they're training to that office, because you were trained by dentist Smith in one practice. You really can't just go to dentist Jones down the street because he might have taught the hygienist there something completely different. And that's
Exactly.
a very disturbing trend in dentistry, is because, like I was saying earlier, you have these dentists that have this highly aggressive mentality of every patient that walks into my office is 32 teeth that need to be crowned. And the other conservative dentist who's just going to watch that amalgam filling for 20 years. I mean, what are they teaching? There's not going to be any sort of homogeneity in education, and they're going to be stuck in that clinic. So that actually creates a whole can of worms in employment law. And so attorneys are going to look at these things differently than what we're seeing, and they're going to see different points of entry into actually calling something like this into serious legal question. Have the conversations with them.
That is a very good insight. I mean, lucky that you had that discussion with her. That is really interesting to see where that would go, especially in a state like Nevada, if that would have passed.
Yeah. And so Arizona, get over to those law schools. There's at least 4 of them in your state.
That should be a huge call to action. Hopefully, Arizona, if you're listening.
Yeah, if you're not listening, listen.
Listen. Okay, so in terms of, and you're from the West Coast, right? You have a good background in the West Coast. California has their own Board of Dental Hygiene. Is that what it's called? Dental Hygiene Board?
They have their own board. Yeah.
Okay. What legal strategies, especially in that area, to have gotten there, what legal strategies do you think are most effective? Like what has worked in the past and what would be most effective in terms of working for getting a dental hygiene board?
So from what I can tell, researching the different paths that different states have taken and the way their regulatory frameworks have happened with the limited autonomy that states have, Colorado's the outlier. We'll talk about Colorado in a moment. They've approached this as a public health initiative, expanding access to care. And so when you approach it from an access to care expansion, it's really easy to get pigeon-toed into dental desert areas or nursing homes or schools, and they don't look at hygiene autonomy broadly. So unfortunately, although there's certain aspects of California's RDH AP model that I actually really like and that I intend to implement in part 6 of the series, and also I'm tentatively working on legislation for Virginia that's going to mirror some of it as well, it's still pigeon-toed in public health arenas. So the RDH AP still has designated spots. They can't work everywhere. So that's some of the limiting factors there. And that holds true with other states too. They try to keep this as tight as possible. Washington State has a minimal autonomous practice part that hygienists can do, but it's again like limited to nursing homes. You can have your own business. You can do on independent practice there, but not anywhere else. Suddenly, after you leave the nursing home, magically you don't know what you're doing anymore. Colorado is an interesting outlier. I was actually talking to one of the leaders in Colorado, and she was explaining the history behind it. I'm not sure if you're aware, or many of your listeners are aware of how Colorado's independence came into play, but it was actually something that the Colorado Dental Association put out in the early 80s, where they went to the legislatures and said, we want to give hygienists full autonomy for 10 days out of the year while we go on vacation. So I get where they're coming from, But the legislators apparently thought that was absolutely ridiculous for them to propose that. But they said, you know what, you can't make this argument that they have the education and the ability to practice independently for 10 days. What happens after day 10? They turn into pumpkins? Like this is ridiculous. So that is actually the story of how hygiene autonomy came to be in Colorado. They didn't push it on a public health initiative. It was actually the dental association that screwed up and overplayed their hand. So when we're talking about hygiene autonomy broadly across the country, I think it's very important that we don't pigeon-toe ourselves into just the public health access to care issues. This is why I think it's extremely important that we look at this broadly as the solution to the staffing shortages, the business issues, and just the general landscape of dentistry as it is right now. If you create pathways for dental hygienist autonomy, you're not going to have staffing turnovers. If you are an autonomous dental hygienist, able to run your own schedule, perform your own diagnoses, your own treatment plans, those patients are yours. You can run your schedule as efficiently as you're able to, and that will make you more productive, which will also turn into a higher income source. And then you are
Exactly.
invested in that practice. And all those patients you're seeing, as preventive measures fail, if they fail, you refer them to the dentist in the office. They're still going to have a happy patient base, but you're going to be efficient. And one of the
Yes.
other points I always like to bring out is from the patient's perspective and from the dentist's perspective, two areas that hygienist autonomy is not talked about enough. If I'm a patient of a dentist and I'm paying for restorative care, whether it's cosmetic veneers or any sort of restorative work, and that dentist is jumping in and out of that operatory to go fish for other restorative procedures in the other rooms, I am going to be pissed. Really, I will be. That's just
Hmm.
such bad customer service. And I don't think
Yeah.
patients always understand that's what's going on. But that's from a business standpoint, that's what's going on. They're jumping in and out of the chairs to do exams that they have to do. They're really looking for their next restorative case. That's just the way it is. But also from a clinician standpoint, and this is something, again, I didn't see until I was working with dentists who were more highly productive and were doing a lot of cosmetic work. They don't want to be disturbed. If they're prepping a 10-unit veneer case, they don't want any distractions because that case has to go really well. And if they have some redundancy regulatory oversight thing, they have to go and do exams on every single hygiene patient. When they're doing that, the office can't run well, and the patient is going to be poorly served because of that. It's not necessary.
Right.
Again, bad business model.
It is. And just, I think of when you're talking about thinking back to the Colorado where you said 10 days and then what do they turn into a pumpkin? That's so true on pretty much every aspect of things that they want us to do when it benefits them.
Mm-hmm.
But then when they want to control it enough, but they're okay with us doing it as long as it is benefiting them in the end. And if I was a business owner, I mean, that's the benefit of bringing in a partner versus just like an associate. If you're bringing in a partner, they're invested. Like you said, you're going to be more efficient. You're going to be more invested into the business, not proposing that dental hygienists become all these partners.
I mean, but it's not an unrealistic idea.
Right.
Yeah.
It just would give more, like you said, more autonomy. You would be more efficient. You would be invested. And if we're okay to do it, that's why the public health thing just kind of drives me nuts. Because why is it okay for us to do this in public health for people that may have limited resources? What are you saying by that? Are you saying that those public health people, it's okay that it's not safe? Because, I mean, there's no safety issue. This has been implemented in many different settings outside of public health, and it's proven to be safe.
The
So why is
studies
it?
are there's so many studies on the efficacy of hygienist autonomy. As I've been doing the research on it, and they keep piling up. I'm like, there's literally a stack of well-reputed research papers showing its efficacy and safety.
Yes, safety. For a long time, it's shown it's been safe. And just to like say, well, public health, it's okay. To me, it's just a big slap in the face for people that depend on public health resources because you're basically saying that they're getting substandard care, which they're not. But then if it's okay for public health, it is okay for the public. Sorry,
Which, well, you make a good point because the scaling assistant thing, some of that's been trying to be sold to legislators as well. We need to expand access to children, pediatric
Yeah.
care, and to vulnerable Medicaid populations. And I actually have an interesting article coming out. Hopefully it's going to be published on Hygienists Hub. It's called Unleashing the Truth. Your dogs are getting better dental laws than you. In Massachusetts, it is illegal for your dog or cat to receive a dental cleaning, hygiene care, unless they're under anesthesia, because they must subgingially scale those teeth. Otherwise, as the American Veterinary Association has well documented, dysbiosis occurs. The same dysbiosis that will occur in human beings. So when they have these hypocritical dentists and organized dentistry saying we need scaling assistance to scale supragingivally, they are either denying the idea that they actually were educated in dysbiosis and the progress of oral disease. Either they don't understand it, or they are shamefacedly telling the public they're willing to commit malpractice on all of these vulnerable populations. It is horrendous when you look at it that way. And that is actually what they're doing.
It's actually already occurring. It's already occurring. And what I see this scaling assistant is almost a backdated, like, oh crap, we are going to get malpractice lawsuits. We need to make this legal soon because I know of hygienists who have worked in offices. They send me ethical case studies all the time because they know I teach ethics. Children have calculus. Children have supra and subgingival calculus. So when you have an assistant who's polishing and you're charging out a prophylaxis, that is malpractice. And they're doing it all day, every day. And so to me, them trying to push this supragingival scaling thing is just like, they're trying to like backdate safety of all of the stuff that they've been doing for years.
So they could, in theory, backdate it and be under the legal threshold for it, but it still is malpractice.
Yes.
Because
you cannot charge a prophylaxis for polishing.
Well, that's an interesting point you make too, because as I was talking about this to some of the attorneys I've been talking to, they've made the point that medicine has actually benefited from major reforms because of torts, malpractice suits. But generally, lawyers are looking more at the medical community than they are at the dental community because there's higher numbers there. And so these, what are still malpractice cases, are going under the radar and nobody's looked at them. This is why we need to be joining hands with the legal community here.
Yeah. And I think unfortunately what's happening, like a kind of an unexpected result of them pushing the scaling is them highlighting the issue. Because I think we've known it's an issue for a long time, and them trying to be like, oh, can we do this? But also we've been doing this, so now we need to make it legal. Hopefully this is patient awareness of like, that's not a legal thing you've been doing this whole time. I think they're putting a magnifying glass on themselves. And
like I said earlier, scrutiny is coming. They opened the door for this, and we are very justified in looking at it.
They opened the door. And I hope that this really highlights for patients the poor decisions and the poor business ethical issues here that have been going on for a while. So that is my hope. We'll move on to the next question. This kind of relates to, again, going back to why is it okay for public health and not for public? How do you respond then to dentists or dental boards who argue that this is a safety issue? And you said you have an article coming out, so I don't want you to give too much, so you can answer vaguely. But how do we show that? There's evidence out there to show that this is safe. How do we present a case?
So we have a stack of positive research studies that show it is safe and efficacious. So we have all of that. But again, hinting at part 4 of my series, we have to also debunk the premise on which this is built. The astounding hypocrisy coming from the mouths of general dentists who, as I will point out in part 4, are leaving dental school with the legal authority to do procedures they have never completed once. In the vast majority of states, it is legal for dentists to do an all-on-4 procedure, never having once placed an implant in dental school. And they will go overseas. They will do courses with little groups on the weekends, the weekend warrior concept, poorly regulated, very little oversight, and then patients become the guinea pigs for their practice. The hypocrisy behind that lack of regulation on dentistry and then them pretending that the non-surgical preventive measures that hygienists are licensed and trained to do somehow are a safety issue for the public is mind-blowing. It's so hypocritical. So there's the hypocritical aspect. There is the positive database of, I have a whole bibliography I posted on our website of research studies for legislators to look at on hygiene autonomy. Safety is not a concern, but I do understand the pushback that organized industry is going to put on hygiene autonomy, which is why whenever I talk about this, and I pointed this out before, is generally the first thing dentists do is they give that argument. Oh my gosh, this is going to be so unsafe. You're going to just let all hygienists loose. They only have associate's degrees. No, that's not what autonomy means. It doesn't mean you snap your fingers and every hygienist is instantaneously autonomous. Pathways for autonomy are what we really need to be looking at. Now, sure, you could adopt Colorado's model and snap your fingers and everyone's autonomous, but the thing with Colorado is there are no safety issues. If you look at the databases in Colorado, the safety issues are with dentists. That's where the complaints are at, not the hygienists, and they've had full autonomy for 40 years. So that's a really hard argument for them to make.
Yeah.
But I still think it's responsible to put pathways forward where we are honoring some of the long-held policies of the American Dental Hygienists Association. We have long held that all hygienists should have baccalaureate degrees. So I think that looking at California's model, AP model, which I think is actually quite sensible, to get your AP license, you have to complete a bachelor's degree in a health science of your choice. It doesn't have to be dental hygiene. You complete 2,000 hours, 2,500 hours, I don't remember what it was, of clinical practice under normal supervisory roles with a dentist so that you have that idea of how referral networks and diagnostics work in a day-to-day practice. And then there's 150 hours, I believe, of specific CE course material on liability, advanced diagnostics, and a couple other things. That's your criteria to get an additional license as an RDH-AP. I feel like the AP should stand for autonomous practitioner. I know it stands for alternative practice, but I really think we just need to redub this and make it RDH-AP and create this pathway and start promoting this across the country. And yes, we all need to start establishing our own dental hygiene boards.
Yes. So, oh gosh, there's just a lot there. So in terms of plans moving forward, what does an organized response look like? I mean, we with Nevada and Arizona, this has become such a social media kind of frenzy. However, what I see happen is things ebb and flow. And unfortunately, when it dies down, we just dealt with this in October. South Dakota Dental Association brought forward coronal scaling. We shut it down successfully. Our state board was very against anything that wasn't CODA accredited. And I think it's because our school has such a good relationship. They understand, how many hours and competencies and everything is required to be CODA accredited. And they were very supportive of that. They said they would not consider any type of licensure at this point. I say that with tongue in cheek, like who knows what could happen. But they have said they will not consider anything that's not CODA accredited, which props to them. When that happened, so many hygienists in the state were just like so passionate and so like ready to come to our town hall meetings and come to this. And it's like, how do we keep that? So we see Arizona, we see Nevada, we see all of this. How do we keep that goal in mind to where we're all working towards this? In my opinion, I just feel like the state association, so ADHA does all they can, but I truly believe that the state associations need to be working closer together to kind of rally together because we all have limited resources. Whereas if all of the states worked better together, I think we would elevate each other. And I'm just kind of rambling, but how do you see this moving forward? If this is your passion project and you want to see this nationally go haywire, how do we get there?
Great question. So interesting you should mention this because Washington State, where I'm from, they actually asked me to lecture on this very issue last weekend. And so I am happy to talk to any state chapters that want ideas, that want, if they see me as a source of energy that would help to make their state chapter like stand up to the plate, I am happy to give that. Also with my research, there is different theories of change models that work broadly speaking across different spectrums. And with the type of change that I'm hoping to accomplish, Cotter's 8-step model for change actually mirrors the most successfully. And his 8-step model is unique because the first step is to create a sense of urgency, which we're doing. But we have to also create small wins. That's step 2. And then as we create small wins, we have to build coalitions. And then we have to get a bigger win. So I'm hoping that in 2026, I can get Virginia to be the next state to make autonomy the thing, so that other states look at this and say, we can replicate this.
Yes, we
That's
can
what
do
we
it
need to
too.
have.
Yeah.
Yes, if we can get it done in Virginia, the rest of you certainly can. And that was what I was encouraging Washington State too, because the politics in these different states are very different. In Virginia, where I'm currently residing, I have to take the case to the legislature. There's no other way to do it. In a state like Washington, you can actually get enough signatures and just take it to a general vote of the public. And they
Well, that's
tried doing
interesting.
that in 1992. It almost passed. Hygienist autonomy almost became
Ooh.
a statewide thing in Washington State in 1992. It failed by, I think it was like 1% of the vote. It was very close. But things have changed there now. Social media is a major thing. The politics of that state have changed significantly since 1992. And I was telling them, you guys, you have, if I was president-elect of Washington State, you better believe that's what I would be going for right now, is getting those signatures and putting this in a statewide initiative and blowing up social media with, articles and statements and videos like, your dog is getting better dental laws than you. Dogs are very popular in Washington State, a lot more popular than dentists.
I was going to say, with all the research that you've done and with all of these articles being published, these articles can be used to educate legislators, educate your lobbyists, educate the public. I just think that you've done so much groundwork for this, that with this momentum, states should just hear this and just be thinking, like, what can we possibly do? How can we use this? I mean, the work is
That
out
was my
there.
purpose. That's why I wrote the
Yes.
series. And I'm putting it out there because I want everyone to take advantage of it.
Yeah.
And please do. Like that was my intention. I'm not putting my name on this and just, hiding it under a table. I want everyone to use this because it doesn't serve me at all unless it actually helps with policy reform. So I want the rest of the country to do this.
Yeah. Yeah. So thank you for all the work that you've done and for all the, research takes so much time and so
It
much
does.
synthesis and reading and putting these things
It's a
together
lot.
in a logical way that everybody can understand. And boy, your first and second article were just so easy to digest. Anybody could read that and really understand what the root of the problem is.
And that was the trick. And that's something I struggle with and I've gotten negative feedback when I give presentations sometimes, is that I'm too technical and it's hard for people to understand what I'm saying. But I always try to, while keeping the academic and scholarly aspects of it, I try to make it approachable to people where they can get it. And I do really think that my upcoming article on your dogs get better dental laws than you is the bumper sticker message that's going to actually make change happen, because you do not need a high academic degree to understand that. That's
Yeah.
when people see that their oral health is being put below the level of animals by dentists for financial reasons.
Let's just say a lot.
Yeah, I feel like a lot of the public and legislators are not going to look favorably at dentists who are bringing legislation like that.
Yeah. Yeah. I agree. Well, I do think that the first two articles were very, very digestible. And so I
Okay,
just
good.
appreciate so much how much backlog time you've put into this. This is going to be an issue for every state because the ADA is not going to back down.
Mm-mm.
With everything that we're hearing from other states, there's a lot being put forward. So this isn't going away. You can kind of not pay attention and not hear about it, but it's not going away. So stay alert, stay in the know, keep reading articles, keep paying attention to this because it's important. And so I would just want to thank you again. I'm just kind of rambling, but thank you so much for
You're
your work on
welcome.
this. Thank you much for your time on the podcast. I appreciate it. Do you have any final thoughts or any last words of advice?
Yes. The final thing I was going to say is we also need to be conscientious that in advocacy, we need to not be seen as the party of no. And right now, when we're opposing the ADA's measures, it's very easy for legislators and public health advocates to look at hygienists as just being the people who are saying, no, you can't do that. No, you can't do that. We have to bring forward our own solutions. Dental hygiene autonomy is that solution. It answers access to care issues. It answers business issues. It stabilizes the workforce. It will encourage people to enter and stay in the hygiene profession because they're not going to see it as a dead-end career. There are so many benefits to dental hygienist autonomy. The only reason why organized dentistry is against it is because of their gatekeeping mentality. There is no science to support their gatekeeping. It is purely gatekeeping.
Yeah. And science, we're evidence-based, right? Everything we do is evidence-based practice. That should bleed into the way that we govern professions.
Yes.
And it's essential. It's 100% essential for us to be employing evidence-based practice, even in the models that we choose to practice in.
Yes.
Thank you so much. Again, I
You're
appreciate
welcome.
your time. I really like talking about this stuff. It's just kind of, again, just my background in ethics. It just kind of, I'm passionate about it, and I can see you are too. And so hopefully we'll see some traction, and hopefully your articles will really, really make a big difference on how people view the whole issue. So
yeah, I hope so.
Thank you. Thank you again. For everybody who enjoyed this content, please like, share, subscribe, comment down below what you took from the message and how you plan on taking this message forward into the greater dental hygiene community, because we all really need support and we need people interested in this. So comment below, share with another hygienist who you think might value this content, and we will see you on the podcast next Friday with a brand new episode. So I hope to see you there. Thanks. Bye.